In this presentation, I'm going to review the diagnosis of diffuse diseases characterized by the presence of multiple nodules and cysts, and I'm going to throw in emphysema as a bonus. And I'm going to emphasize the high-resolution CT appearances of each of these entities. Now, I'm beginning with 5 unknown cases. These are each classic and typical examples of a relatively common disease and an important disease to know about in diagnosing nodules and cysts. Each of these will appear during the lecture, and if you come back and review this lecture later on, look at each of these 5 cases, you should be able to recognize what they are by their appearance. Unknown case 1, multiple nodules occurring in clusters along the fissures, along the pleural surfaces, and along vessels and bronchi. Number 2, multiple very small nodules, diffuse, very sharply marginated. Number 3, again, another example of multiple nodules with a diffuse distribution. These do not involve the pleural surface. Number 4, a patient with irregular thick-walled cysts involving the upper lobes and a distinct upper lobe predominance. The lower lobes are less seriously involved. Very typical example of that entity. And unknown case 5, diffuse, thin-walled, round cysts, very typical of this entity. These are 5 appearances you will learn to recognize in this presentation, and these are ones you should know about. Now, I'll begin with a brief description of the secondary pulmonary lobule. A number of the abnormalities I will discuss are based on abnormalities of lobular architecture. This is a nice example of a radiograph of a lung slice of 2 adjacent secondary pulmonary lobules. They're marginated by connective tissue interlobular septa containing pulmonary vein and lymphatic branches. In the center of the pulmonary lobules is the centrilobular artery. This is visible on high-resolution CT in normal subjects. Adjacent to that is the centrilobular bronchiole. It is not visible in normal subjects on high-resolution CT. This is an example of interlobular septal thickening on high-resolution CT, and this has nothing to do with my presentation, but it's a nice example of lobular anatomy as we appreciate it on high-res, and gives you some idea of where or what pulmonary lobules look like and what the centrilobular region looks like. In this patient with interlobular septal thickening, we can recognize the lines we see as interlobular septa because they outline what we can recognize as secondary pulmonary lobules. That pulmonary lobule outlined by the red arrows looks very much like the ones I just showed you. In the center of the lobule is a branching centrilobular artery centered about 1 centimeter from the pleural surface. Now, when we identify multiple lung nodules on high-resolution CT, we look for a specific high-resolution CT distribution, and these are classified as one of 3 different types: a perilymphatic distribution, a random distribution, and a centrilobular distribution. These have different characteristics. They are easy to recognize, and each has a different differential diagnosis. This is a nice example of the distribution typical of a perilymphatic pattern. With this distribution, nodules are occurring in relation to pulmonary lymphatics. Wherever they occur in the lung, we see them in relation to the pleural surfaces, peripherally, and adjacent to the fissures, representing 2 pleural surfaces. Nodules occurring in this region are typical of this pattern because lymphatics are very rich in this region of lung. In addition, you see nodules in the peribronchovascular region adjacent to large or small vessels or bronchi, typical of a perilymphatic pattern. And you may see nodules in relation to interlobular septa. These 3 locations are typical of a perilymphatic pattern. And if you look at the yellow nodules shown on this slide, their overall distribution appears patchy because the nodules are occurring specifically in relation to these structures. Differential diagnosis of a perilymphatic pattern. Sarcoidosis is the classic example. Most patients with this distribution have sarcoid. Lymphangitic spread of carcinoma is a less common cause but may be seen. Silicosis and co-workers pneumoconiosis also show this distribution, but it's a relatively uncommon disease unless you live in a specific part of the country. And then very rare causes, amyloid and LIP, lymphocytic interstitial pneumonia. For practical purposes, the differential diagnosis is the top 2 diseases on the list, and sarcoid is usually going to be the cause of perilymphatic nodules that we see. Here a very nice example of sarcoidosis on high res. This is case number 1. What we see are numerous nodules contacting the pleural surface, arising at the pleural surface peripherally and arising at the pleural surface in relation to the fissure, a very, very typical appearance, typical of a perilymphatic pattern and typical of sarcoid. What we see here is the surface of a lung in a different patient. We are looking through the pleural surface, and what we see here are clusters of sarcoid granulomas occurring immediately beneath the pleural surface, just like what we see on the high-res CT. Now, also notice in this patient there are clusters of nodules occurring in relation to the central vessels and bronchi. This is typical of a perilymphatic pattern and typical of sarcoid. Here we see on a lung slice in a different patient the clusters of nodules occurring surrounding a central bronchus. Very, very typical appearance on high-res and typical on pathology. Now here another patient with sarcoid. The distribution of nodules we see here looks virtually the same. Nodules are visible at the pleural surface along the fissure and at the pleural surfaces peripherally. We also see nodules clustering in relation to central bronchi and vessels, a very, very typical appearance, virtually diagnostic of sarcoidosis, and this is a very nice example of a perilymphatic pattern. Now this, of course, is the appearance of sarcoid on a chest radiograph. What we see is a predominance of nodules in the upper lobes, and in this patient who has some lung fibrosis, the pulmonary hyla appear elevated, quite common in patients with sarcoid. Here the CT that accompanies that chest film, and you can see the nodules predominating in the upper lobes. We see nodules at the pleural surfaces peripherally, and this large mass or irregular mass in the left upper lobe is a conglomeration of nodules occurring in relation to central vessels and bronchi. Again, a typical perilymphatic pattern. These conglomerations of nodules quite common in patients with bad sarcoid. Now here are histologic and radiographic examples of interlobular septal thickening and nodularity in lymphangitic spread of carcinoma. You can see nodules within the interlobular septum here marginating this pulmonary lobule on histology. And on your right is a radiograph of a lung slice in a different patient who has lymphangitic spread of carcinoma, but the arrow is pointing to nodular thickening of the interlobular septum. Again, nodules within the septa are typical of a perilymphatic pattern. And here a lung slice in a different patient with lymphangitic spread of carcinoma, but you can again see nodular thickening of interlobular septa as part of this pattern, typical perilymphatic disease. Here a patient with breast carcinoma and lymphangitic spread with nodular septal thickening. The arrows are pointing to interlobular septa that show clear-cut nodular thickening, again part of a perilymphatic pattern and typical of lymphangitic spread, the second most likely cause of this appearance. So the significance of this pattern when identified, sarcoid is the classic cause and usually the cause of the case you're looking at. Lymphangitic spread of tumor is less likely but also possible. Clinical history may be sufficient for diagnosis. If the patient has a known tumor, you're going to think about lymphangitic spread. If the patient is relatively asymptomatic, you're going to think about sarcoid. And then the overall distribution may help in narrowing the differential diagnosis, and by that I mean whether it's upper lobe or lower lobe, unilateral, bilateral, those sorts of things. Sarcoid typically has an upper lobe predominance and is usually but not always bilateral, and it may not uncommonly be asymmetrical. Lymphangitic spread of tumor has a variable distribution, may be upper lobe, may be lower lobe in predominance, and may be unilateral in some cases, particularly those with lung cancer. Silicosis and co-workers pneumoconiosis, the disease has a distinct upper lobe predominance and it will be symmetrical. The second type or pattern of nodules we can recognize is so-called random distribution, and with a random distribution the nodules are occurring randomly relative to lung structures. They occur anywhere and everywhere they want to. Therefore, they are seen in a subpleural location, but they do not predominate in relation to the subpleural lung as they do with sarcoid. Because they occur anywhere and everywhere, the appearance of a random distribution is uniform. The nodules seem to be involving all lung regions equally. Differential diagnosis of a random pattern is that of hematogenous disease, miliary TB, miliary fungal infections, hematogenous metastases, and occasionally when sarcoid is extremely diffuse, it may mimic a random pattern, but it's not very common. This is a very nice example of a random pattern in a patient with miliary TB. Notice if you look at the lung periphery, you can see some of these small nodules arising at the pleural surface, but the overall appearance is diffuse and uniform lung involvement. It looks very different from the distribution of sarcoid that I showed you before. And here is a lung slice in a different patient with miliary tuberculosis. Notice the presence of nodules along the fissure, along the pleural surface, but the overall distribution we see is diffuse and uniform. An example of miliary TB on chest radiograph, you cannot recognize that this is a random pattern on a chest film. You can't see the presence of subpleural nodules, etc. But this appearance we usually see on a plain film is rather diffuse and uniform lung involvement. Looks sort of like the CT scan without recognizing the precise distribution. And here another example of a random pattern. Notice the presence of nodules involving the peripheral pleural surface, but the overall distribution we see is diffuse and uniform. This is miliary cocci in an AIDS patient. Chest film shows again a diffuse, rather uniform appearance to lung nodules as shown, typical of this pattern. Here is a patient with an adenocarcinoma involving the left upper lobe presenting as a 2-centimeter nodule. This patient has developed hematogenous metastases from this tumor, and you can see numerous very small nodules scattered throughout the lung parenchyma. Notice the presence of nodules at the pleural surface, typical of a random pattern, but again, there is no predominance of nodules in relation to the pleural surfaces. Diffuse and uniform lung involvement, typical of this pattern. So the significance of a random pattern, metastases or miliary infection very likely, and again, history will likely help you in making the distinction between these two. The third pattern we can recognize is so-called centrilobular, where nodules are occurring in relation to the centrilobular artery or bronchiole. Because of that, the most peripheral nodules you see will be centered from 5 to 10 millimeters from a fissure or from the pleural surface. When a nodule is large, it may touch the pleural surface, but these nodules do not arise at the pleural surface, as do nodules in both a perilymphatic and random pattern. Because lobules are all about the same size, these nodules appear to be evenly spaced throughout the lung, and this may mimic a random pattern, except for the absence of pleural nodules. In some patients, this pattern may be patchy rather than diffuse, as shown on this slide. Here a very nice example of a centrilobular pattern shown on high res. This was unknown case 3, I believe. Numerous nodules scattered throughout the lung parenchyma. If you look in the lung periphery, the most peripheral nodules you see are centered 5 to 10 millimeters from the pleural surface. In this patient, about 5 millimeters. If you look along the fissure, you can also see that nodules are separated from the fissure. The most peripheral nodules adjacent to the fissure, about 5 to 10 millimeters from the surface of the fissure itself. So a centrilobular pattern. This a very typical example of hypersensitivity pneumonitis, one of the causes of this pattern and distribution of nodules. This is a very simple algorithm that can allow you to diagnose these 3 different distributions of nodules with a very high accuracy. We tested this, and its accuracy was about 95%. If you start with multiple nodules, you don't see any pleural nodules, you don't really need to look for anything else. All of a sudden, you make the diagnosis of a centrilobular pattern. This would be characteristic of diseases involving small airways or small vessels in a centrilobular location. If, on the other hand, you start with multiple nodules and subpleural nodules are visible, if the overall distribution is diffuse and uniform, then it's a random pattern, differential diagnosis as we discussed. And if you see subpleural nodules, but they're patchy or non-uniform and specifically involve those different components of a perilymphatic pattern, then it's a perilymphatic distribution. Sarcoid would be number 1 on the list, lymphangitic spread number 2. Centrilobular nodules, differential diagnosis. Most causes of this pattern are airways diseases, and some sort of bronchiolitis, infectious or inflammatory. It may be endobronchial spread of TB or MAC, any cause of bronchopneumonia. Hypersensitivity pneumonitis, as I showed you already, is a common cause of a central lobular pattern. Endobronchial spread of tumors, such as bronchiolo-alveolar carcinoma, BAC, can give central lobular nodules. Pneumoconiosis, such as silicosis, gives you early abnormalities in relation to central lobular airways. Organizing pneumonia, a rare cause. Histiocytosis, a rare cause. Everything I've mentioned so far is an airways disease, and then bringing up the rear. Vascular causes, pulmonary edema or vasculitis, may result in this appearance, but the vast majority of cases causing a central lobular pattern of nodules are airways diseases. Here a nice example of bronchiolitis on a high-res CT. You can see these central lobular nodules, and actually you can see an airway inside of these. This nodule of inflammation is surrounding the central lobular bronchiole. And on the right side is a pulmonary lobule outlined by the blue arrows, and in the center you can see a nodule of inflammation in association with the central lobular bronchiole. Again, bronchiolitis, a common cause of this distribution or appearance of central lobular nodules. Here a 27-year-old with cough, shortness of breath, and fever. You can see some areas of cavitation in the lower lobe. In addition, multiple central lobular nodules, the most peripheral of these, centered about 5 millimeters from the pleural surface. This is endobronchial spread, multi-drug resistant TB. Here another patient, shortness of breath and fever, a sort of patchy distribution, clusters of central lobular nodules, again the most peripheral ones about 5 millimeters from the pleural surface, bronchopneumonia. Hypersensitivity pneumonitis, another example, with hazy ground glass opacity central lobular nodules, the most peripheral ones about 5 millimeters from the pleural surface. Here a patient with endobronchial spread of bronchiolo-alveolar carcinoma, again central lobular nodules occurring in clusters, some larger nodules, and areas of consolidation as well, but another cause of central lobular nodules. Here a lung slice in a different patient with bronchial cell carcinoma and endobronchial spread, but you can see these central lobular nodules centered about 5 millimeters from the pleural surface. Okay, the significance of this pattern, well, it's usually going to be a small airways disease or bronchiolitis. Consider infection, it's probably the most common cause. In a patient with an appropriate history of exposure to birds or mushrooms or fungus or something of that sort, the appearance may be diagnostic of hypersensitivity pneumonitis. Remember BAC. Do not forget the possibility of endobronchial spread of tumor when you see this appearance. Those would be the three most likely causes, the three things I would list in differential diagnosis when I saw this pattern. Okay, another appearance is tree in bud. This is an appearance that results from dilatation and impaction of central lobular airways. It resembles a budding tree. If it did not resemble a budding tree, this would be a really stupid name, but it does resemble a budding tree. Centered 5 to 10 millimeters from the pleural surface, because the central lobular bronchiole is in that location. More conspicuous than normal branching vessels in the lung periphery and often associated with central lobular nodules as well. Here an example of what tree in bud looks like. Again, this represents a dilated, impacted central lobular bronchiole. Sometimes you can see the buds without the branches clearly seen and appreciate it as a rosette of small nodules. Here another nice example in a patient with cystic fibrosis. In a study that was done a few years back, among 27 cases, all had infection, common in patients with bronchiectasis and bronchopneumonia. A patient with age-related airways disease, a number of nice examples of tree and bud in the right lower lobe. You can see those are central lobular in location. This is a lung slice in a different patient with a similar type of infection, but you can see these branching, impacted airways in the lung periphery, resulting in an appearance of tree in bud. Differential diagnosis: endobronchial spread of TB or MAC with infection, bronchopneumonia with infection, bronchiectasis or bronchitis with infection, cystic fibrosis with infection, panbronchiolitis, a disease that's rare in the United States, common in Asia, with infection, aspiration, a rare cause of this, ABPA, allergic bronchopulmonary aspergillosis or asthma with mucus plugging, rare, bronchioalveolar carcinoma, rare. The large majority of causes of this appearance of tree and bud are infection. Another example, a prone scan in a patient with a number of nice examples of tree and bud, little branching things in the lung parenchyma, Pseudomonas bronchopneumonia. The significance of this finding, it's a very characteristic appearance. It's easy to recognize. Almost all cases have infection. This is a virtual slam dunk for some sort of infectious disease. The diagnosis is in the sputum. You don't have to do a lung biopsy when you see tree and bud. You have the patient spit in a cup, and then you look in the cup, and that's what the disease is. Okay, emphysema. We will now move on to something other than nodules. Emphysema is classified histologically as three types: centrilobular, panlobular, or paraseptal. Centrilobular emphysema is common and associated with smoking. Pathology shows areas of emphysema surrounding the centrilobular bronchial and artery. High-res CT shows centrilobular lucencies, or sometimes simply spotty lucencies, without visible walls in most cases, and a distinct upper lobe predominance. This is what it looks like on high-res CT. You see these spotty lucencies involving the upper lobes without walls being recognized. If you look at a close-up view in that same patient, the red arrows are pointing to the centrilobular artery with the emphysema surrounding that. This is a typical appearance of centrilobular emphysema. On chest radiograph, what we will see is emphysema that predominates in the upper lobes. The upper lobes appear relatively lucent, the lower lobes relatively dense with larger vessels. Here a reconstruction in a different patient with centrilobular emphysema, but you can see the predominance of these spotty areas of lung destruction in the upper lobes. Panlobular emphysema is uncommon. It's associated with alpha-1 antitrypsin deficiency, sometimes seen in smokers. Pathology shows uniform destruction of the secondary lobule. High-res CT shows lungs that are too big, too black. Pulmonary vessels appear very small within the abnormal lung. Focal lucencies, or bullae, or focal areas of lung destruction, are usually absent. And this will appear diffuse or have a lower lobe predominance. This is typical panlobular emphysema in a patient with a left lung transplant. For comparison, the right lung is too big, too black, and the vessels are too small. But you do not see focal areas of lung destruction or bullous lesions. Chest radiograph in a patient with panlobular emphysema. Notice that lucency we see here is basal in distribution. The vessels at the lung bases are smaller than those in the upper lobes. This is typical of alpha-1 antitrypsin deficiency. And here the corresponding CT scan with lungs that are too big, too black, and have small vessels. The last type of emphysema is so-called paraseptal. It's common and occurs as an isolated abnormality or in smokers with centrilobular emphysema. It's associated with spontaneous pneumothorax. Pathology shows uniform or destruction of subpleural lobules. High-res CT shows subpleural lucencies marginated by interlobular septa. If these are larger than a centimeter, by definition, they are called bullae, but it's exactly the same thing. Upper lobe predominance. And here, typical paraseptal emphysema with the areas of lung destruction being subpleural in location. When they're larger than a centimeter, they are bullae. Lung cysts. A cyst is an air-filled lesion, localized, thin-walled, well circumscribed, and according to the current definition, larger than a centimeter. That is what a lung cyst is. The differential diagnosis of diseases characterized by lung cysts, well, honeycombing is a cystic disease, so anything causing honeycombing results in lung cysts. Emphysema with bullae, cystic bronchiectasis, nematoceles associated with pneumonia, such as pneumocystis. And some patients with hypersensitivity pneumonitis will have cysts, but this is relatively rare. The list I've reviewed so far are relatively common lung diseases that may be associated with cysts. However, there are several lung diseases that present with cysts as the primary manifestation, and they are all rare. And these are histiocytosis, lymphangiomyomatosis, LAM, and the lung disease associated with tuberous sclerosis, which is basically LAM, also rare, and Sjogren's syndrome or other collagen disease with lymphocytic interstitial pneumonitis, also rare. So the three diseases at the bottom of the list are primarily cystic diseases, and they are quite rare in clinical practice. Here is a patient with very irregular, thick and thin-walled cysts involving the upper lobes. This is histiocytosis and a quite typical appearance. What we see are cysts that are very irregular in shape. They may be fused or cloverleaf in shape, thick or thin-walled. Intervening lung looks normal. There's no intervening lung fibrosis. Distinct upper lobe predominance. Pneumothorax may occur if these rupture. Nodules may be seen in association with the lung cysts in relatively early cases, and this is considered to be a smoking-related disease in adults. It is very rare in adults to have histiocytosis unrelated to smoking. Another example, this was case number 4, I believe, multiple irregular upper lobe cysts with smaller cysts and less numerous cysts at the lung bases, so a distinct upper lobe predominance with this very irregular appearance typical of histiocytosis. This is an example on chest radiograph. The lungs look relatively large. The upper lobes look relatively lucent because of the predominance of cysts in that location, and you may see a very minimal reticulation. This is a woman with early disease, 21-year-old woman with cough, and we see a combination of thick-walled cysts and cavitary nodules and distinct nodules involving the upper lobes with many fewer at the lung bases. She is a smoker, and this is typical of the early stages of histiocytosis where nodules and cysts coexist. Now here is another patient with very large lung volumes, maybe a very minimal increase in reticulation. This is lymphangiomyomatosis, or LAM. Notice that this is a woman, and this disease occurs only in women. Here is LAM, a nice example. Scan through the upper lobe shows a number of small, rounded, thin-walled cysts, very typical. And notice that we're seeing just as many cysts at the lung bases. This disease does not have any upper lobe predominance. It is diffuse in distribution. Cysts are round in shape in this disease, usually thin-walled. Intervening lung, again, looks normal, no associated fibrosis. The distribution is diffuse. Pneumothorax may occur again because of rupture of these. Occurs only in women of childbearing age. 1% of patients with tuberous sclerosis will show a similar abnormality, and I believe there has been one man reported with LAM in tuberous sclerosis, but LAM without tuberous sclerosis, to my knowledge, only in women. This is the same patient and a scan 2 years later showing progression of disease. This is a progressive disease, and these people become very, very short of breath. She had a lung transplantation, and here is her excised lung, and you can see it's been replaced by numerous cysts. This is an example of lymphangiomyomatosis occurring in tuberous sclerosis. We can see lucency involving the upper lobes and pleural effusions. Pleural effusions may occur in this disease. Chylous pleural effusion specifically because of involvement of hilar and mediastinal lymph nodes. And lastly, this is Sjogren's syndrome, a patient who has Sjogren's and LIP, or lymphocytic interstitial pneumonitis. Notice the presence of numerous thin-walled cysts, but the cysts in this disease tend to be more limited in number than in the other diseases I have shown you. Most patients with LIP and Sjogren's or other collagen diseases will have a dozen or so cysts or fewer. In summary, we've reviewed a number of different cases, nodules and cysts. Here are the unknowns again. First case, a typical perilymphatic distribution in sarcoidosis with nodules occurring in relation to the pleural surfaces and central bronchi and vessels having a patchy distribution. Here, unknown case 2, a patient with miliary tuberculosis. Nodules are diffusely involving the lung parenchyma. Pleural surfaces are involved. You can see nodules arising at the pleural surface, typical of this disease. Case number 3, a centrilobular distribution where the nodules are sparing the pleural surfaces, hypersensitivity pneumonitis with a typical appearance. Unknown case 4, very irregular thick-walled cysts involving the upper lobes, fewer cysts at the lung bases, typical of histiocytosis. And lastly, numerous thin-walled, rounded cysts involving the lung bases to an equal extent as the upper lobes, typical of lymphangiomyomatosis. Thank you very much.